Medurstand Understanding Medicine.
We have covered the entire curriculum, and today we are going to discuss just some of the miscellaneous abnormalities. My institution affiliations: I am currently Professor of Medicine at Rashtrati Medical College and also Senior Vice President, Pakistan Society of Internal Medicine. Now, this is the ECG. There is an abnormality which you can appreciate if you see this like we normally do 1, 2, 3, AVR, AVL, AVF, then V1, V2, V3, V4, V5. This is something which is very unlikely in our country because this is related to ambient temperature. Of course, we also have cold weather and we also have some parts of country which have minus 10 degree temperature, but most of our country is very warm, so very unlikely to see this abnormality. But of course you need to know. If you see this one, there is PR interval. This P looks normal, but PR interval looks little longish. But then look at this QRS complex. There is a normal R wave, but before it touches the baseline, it rises again, and then there is another big, very broad wave, the J wave, or also called Osborn wave. If you enlarge it, you can appreciate it better. This is the enlarged version. You see, the PR interval is longish. It is definitely more than 0.2, which is upper normal. It is longer than normal. And normal upright R wave, it almost touches baseline, but then rises again. This is the abnormal wave called Osborn. And this interval also looks longish, and it looks as if the whole ECG is stretched like this. Every interval is prolonged, like PR interval is prolonged, QRS is broadened, and this QT also looks to be stretched or prolonged. This is called hypothermia. Somebody stuck in hypothermic state remains there for many hours, usually found uh, unconscious or in a state of absolute motionless state, and when you do an ECG you might find this one. The diagnostic criteria: Osborn wave. Osborn wave may also be seen in electrolyte abnormalities, in calcium related disorders, as I showed you earlier. But it is seen in more classical form here. Osborn. Osborn, of course, is the name of the scientist who discovered this, who described, and these are also called J waves. J because J refers to junction of QRS with ST. And there is prolongation of everything: P wave, PR interval, QRS, and T. So everything is prolonged because actually the heart rate is slowed down, and there is generalized reduction in metabolism leading to these changes. Then this may predispose to various arrhythmias. Patient may show various arrhythmias like VPCs, APCs, bradyarrhythmias, tachyarrhythmias. So they may be additional feature. But diagnostic criteria is presence of Osborn and stretching of all the waves. Hypothermia. Just examine the ECG: 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5. What do you see? This is the sign. This is the rhythm strip. I think there is no problem with the rhythm. PQRS relationship is intact. We have as many P waves as QRSs, but this T wave looks very prominent, very broad and prominent, and QT interval also looks somewhat prolonged. If you enlarge it, then you will appreciate it better. Now I just calculated from QT interval is the interval starting with a Q corresponding to this end of the bar and ending with the T wave. So this interval, QT interval, is normally 0.40 or less if your heart rate is normal. Now, if heart rate is fast, this QT interval will become short, and if heart rate is low, then this QT interval will be prolonged. That is normal physiological pattern. So that is why whenever you see abnormal QT, you should correct it for the rate. If rate is normal, like in this patient, what is the rate? I think 5, 10, 15, 20, 25. It's like some 75 something. So if the rate is normal, then observed QT will be QTC also. But if the rate is high or if the rate is low, then you would need to correct the QT interval. So this is long QT syndrome. This is usually an asymptomatic incidental finding in young people, and there may be family history of sudden deaths because long QT interval is asymptomatic disease, but it predisposes to certain fatal arrhythmias. Theoretically, any normal healthy person may have occasional ventricular tachycardia. If a T wave follows, if the R wave drops at the downslope of T wave. But in patient with prolonged QT interval, since the vulnerable phase is longer than normal, so they have more chances. I'm going to show it to you in a graphic form, which I showed you earlier, but in this video also I'm going to explain it. Criteria: QTC or QT is more than 0.40. Patient not on certain medication. Now this is important. I think very, very important. There are many drugs, some anti-cancer drugs, some anti-malaria drugs, some anti-arrhythmic drugs, some antihistamines. You could actually, there's a long list. It is not possible to memorize that long list. So there are many drugs which can cause transient or permanent QT prolongation. So if you just observe this abnormality in any person, I think you must go through all the medication patient is taking and then go through the literature and find out on internet if that drug can be responsible for prolongation of QT. If that is not the case, then you can make a diagnosis of idiopathic or inherited this long QT syndrome. Now, this is what I have explained. In a normal person, depolarization starts, it ends here, immediately followed by repolarization, and then all muscles are in the refractory state. But at the end, in this part, this is vulnerable zone. But if you have long QT interval, your vulnerable zone is longer. For simple reason, since the vulnerable zone is longer, then more chances that a just incident R wave or VPC following, and this may trigger ventricular tachycardia. This is even more rare. This is again seen in those families where there is history of sudden death. It is supposedly not very rare, but not very well known. What do you see? Do you see any problem in this ECG? Of course, there is some. That's why it is here. See this, V1 and V2. One, QRSs are slightly prolonged. Two, there is a wave, an abnormal wave at the end of QRS complex, and there is ST signal elevation also. This is it. This is the magnified view. You see this PR interval, QRS complex, and then there is a big, ugly, broad J wave type thing. And then it is followed by T wave inversion. This is Brugada syndrome. Brugada is a scientist. He is still alive. I actually met him once. So this is Brugada syndrome, and this may be responsible for sudden death. So if you have somebody who shows this ECG and he has a family history of sudden death, this may be called Brugada syndrome. You cannot make the definitive diagnosis of Brugada syndrome unless there is family history of sudden death or there is history of tachyarrhythmias. Just ECG abnormality, you may suspect. I think ECG abnormality alone may not be sufficient to label somebody as Brugada unless there is a family history of sudden death or history of tachycardia. What are the diagnostic criteria? Broad QRSs, but not as broad as we see in the right bundle branch or left bundle branch block. The pattern will be that of right bundle branch block, because in V1 we have secondary R wave in right bundle branch block. Here also you have an additional wave. Actually, it is not possible to say the exact duration in this QRS complex. Here you can say it is broad definitely, but not as broad as you would expect in bundle branch block. Prolonged PR more than 0.2, J point elevation and a wave, and coved or concave ST segment. These are convex or concave or coved. Coved is an English word. It also refers to, I think, the same morphology as concave. And that is that kind of morphology, ST segment elevation, and history of tachycardia, ventricular tachycardia, or family history of sudden death is required to make a diagnosis of Brugada syndrome. These were actually two brothers, the Brugada brother, who described this condition. What do you see? When you examine limb lead 1, you immediately notice that things are not right. P wave is inverted. QRS complex is also inverted. Normally it should be upright, but here it is inverted almost completely. So PQRS, this entire process is inverted in one and then AVL. So what do you suspect? I think there are two possibilities, three possibilities. Maybe extreme right axis deviation. If there is right axis deviation, then P wave should be upright, because right axis deviation should affect only ventricles. So P wave should be upright. So I don't think I would consider a right axis deviation. Then technical dextrocardia. This was, I think, discussed in one of the earlier videos, where you simply wrongly place limb lead 1 electrodes. Right arm and left arm electrodes are reversed. You can have that kind of thing. There will be P wave inversion and QRS inversion. When you examine these limb leads, definitely there is a possibility of technical dextrocardia. But when we examine precordial leads, V1, V2, V3, V4, V5, V6, there is no progression of R wave. If you can see here, like here, when we place lead from this one, this is V1, V2, and then this one, as leads pass over the heart, there is evolution of R wave. R wave becomes taller and taller. But in this case, that does not happen. It becomes small actually, and then V1, V2, V3, V4, V5, the R wave does not progress. It becomes actually stunted. Why? Because heart is not on this side. This may be a case of dextrocardia. As compared to technical dextrocardia, which is just the wrong placement of ECG, this is true dextrocardia. Of course, when you examine this patient, you will hear the sound on the heart sound are present on the right side. This patient may also have liver on the left side and spleen on the right side, and this is called situs inversus viscerans. So this is technical dextrocardia. No, this is true dextrocardia. So what are the criteria? Inverted PQRS complex in lead 1 and AVL. Failure of evolution of R wave in precordial leads. Right? So this is diagnostic feature of dextrocardia. So that completes the module on miscellaneous condition, and that also completes our entire ECG course. It was a pleasure having this interaction with you. I hope you liked it. I'm going to leave the URL of my this entire playlist, so for your future reference. Professor Azizur Rahman from Medurstand. Look forward to see you in my other videos. Thank you.